So now for the objective physical exam of the abdomen. So now this is different. For the abdomen, we do it in a different order, different than any other body system. So write this down because it comes up over and over again on test questions.
Uh-oh.
The order for this one is going to be IAPP. So the mnemonic I want you to remember in order to remember this order, because not only does auscultation get mixed up, but palpation and percussion also get flipped. So I want you to think of this mnemonic. I always percuss patients. I standing for inspection, that first step, always. But now the second step, A for always, that stands for auscultation. So inspect, auscultate, listen, and then percuss stands for that first P, which is now percussion, and then the patients will be the PA in patients, should help you remember the PA for palpate. So one of the reasons why we do this order different, we want to auscultate or listen with our stethoscope before we start pressing around, because once we start pressing around, we can actually increase bowel motility. So it'll change what we're going to hear. So let's go ahead and get started.
All right.
So you would want to look at the patient's bare abdomen. So first I'm looking at my patient and I'm inspecting. And you would notice the contour of the abdomen. So contour is just a fancy name for the shape. And you're looking rib cage to hip bone. What is the generalized shape? If you can draw a straight line, then we say their abdomen is flat. So this patient's abdomen, there's a straight line from the rib cage to the hip bones, so they have a flat abdomen. If you had a patient that was really thin, so maybe they were cachexic, malnourished, and they had a scooping out from the hips to the rib cage, that would be called scaphoid.
Scaphoid.
Scaphoid, or I like to think scaphoid and think there's a void where it's been scooped out. And again, you can see that with someone who's really thin or even might have cachexic or be anorexic or someone who's malnourished. If you had a roundness to it, we call that rounded appearance. And that happens with someone who is overweight, early signs of pregnancy. That can also happen with an infant. They have those little infant pot bellies.
Oh, that's cute, yeah.
And then if it was very much rounded over the top, we call that protuberant. So we can see that with someone in third trimester pregnancy, so very far along. Also, sometimes a toddler, because toddlers can have that lordosis of the spine, which gives them that little toddler pot belly that looks so cute in bikinis. Or if they have ascites, or if they're morbidly obese. So again, the four different shapes are flat, scaphoid, or I call it scaphoid, rounded, and protuberant. It's important to know the difference between those four.
Now for a practice question. The nurse is assessing a 2-year-old child, the toddler. What type of abdomen would the nurse expect to find? The correct answer is protuberant. Hey everyone, Nurse Mike here from SimpleNursing.com. Did you get your beautifully handcrafted study guide bundle yet? It highlights the key points and memory tricks in this video. Plus, get 900 more videos not here on YouTube, all neatly organized in the playlist, along with thousands of practice questions written by actual NCLEX writers. So don't be scared, be prepared. Try it free today. Visit SimpleNursing.com.
So now that we've looked at the shape and the contour of the abdomen, we're now going to look and see if it's symmetric. Remember, we love symmetry, like the right side to match the left side. So we want to make sure that there's no bulging, no pulsations. You can even look and see if the client bears down, or they do that Valsalva maneuver, or maybe even if they cough. If there's anything that pokes out, which could be a sign of a herniation, which that could happen at the umbilicus. That could also happen if they'd had a surgery anywhere. You can get an incisional hernia. So you're looking for anything that pokes out or pops out at you.
It's never a good thing.
If they cough, or if they bear down, do any type of pressure, or lift a heavy object. And remember, it's also just skin. So you're assessing the generalized skin tone, looking to see, are there any piercings, any tattoos, any concerning moles? So we would still do our normal skin check. Is there any moles that would be at risk for skin cancer? And also any scars in the abdomen will tell us if they've had surgery in the past. And then finally, like we talked about before, we'll look for any stretch marks or striae. And we'll know if they're fresh or if they're a little bit older based on the color. Because remember that fresh ones are going to look purple, red, blue, whereas older ones are going to look silvery or white in color, which could let us know, say, if someone had new onset of ascites, where all of a sudden their abdomen became protuberant, then they would have those new stretch marks. So we might be looking for some new finding that caused that edema or fluid buildup in the abdomen. So next we can move on to our second step, auscultation. So with auscultation, and actually the pattern that we are going to utilize for the rest of the abdominal assessment, is we're always going to start in the right lower quadrant, and we are going to move clockwise. So we're going to start in the right lower quadrant, moving clockwise. And one of the big reasons that we do that is because that's the way fecal matter moves.
Ah, okay.
And so oftentimes we can expect to hear sounds primarily in this quadrant, or say if a patient had gone to surgery and they had anesthesia, so we're waiting for bowel sounds to return, then that might be one of the first places they start. And so one of the big things especially is we're going to be going 3 to 4 spots in each quadrant and moving in a side-to-side zigzag pattern. So we're going to listen with our diaphragm, because remember, our diaphragm listens for those louder sounds, those normal bowel sounds, and so that's what we'll be listening for. So we'll make sure we click it to the right side, and we'll start auscultating. And what we're listening for are these little clicks and gurgles. Kind of sounds like a little stream or like a bubbling brook.
Mm-hmm.
And I can tell my patient might have just had lunch because I've got a lot of activity going.
So it sounds like.
And so we do this side-to-side zigzag pattern going clockwise. And what we want to hear is 5 to 30 clicks and gurgles per minute. Also, what's important is when we're listening, to say that the sounds are as active as we want, we not only want to hear 5 to 30 clicks and gurgles per minute, but we also kind of want to take our time. To do an appropriate abdominal assessment, we want to take a minute to a minute and a half in each quadrant.
A whole minute to a minute and a
whole
half.
minute. So I actually went a little bit fast for the purpose of the demonstration. So you want to do a minute to a minute and a half in each quadrant. So that should take you at least 4 minutes. And that's if you hear things. However, if you don't hear anything, in order to say that your patient has no bowel sounds at all, you have to listen for 5 full minutes in each quadrant.
5 full minutes. That's a long time.
That's 20 minutes total.
Wow.
To say that it is absent. Because you don't want to say it's absent, but really you just moved on before it happened. And so that would be in order to say that it's absolutely absent. So what's the difference between absent and what we are expecting to hear? So the terms that we use, if you hear the 5 to 30 clicks and gurgles per minute, we call that normoactive.
Like sounds like normal, right?
Like normal and activity, and they smushed it together into one word.
Normoactive.
Which makes it easier to remember. So normoactive. And that means we hear 5 to 30 clicks and gurgles per minute. So if we hear normoactive bowel sounds, which are loud, kind of easy to hear with your stethoscope, then you can do a minute to a minute and a half in each quadrant. So let's say it was more than that. Let's say they're either louder or much more than that 5 to 30 clicks and gurgles. Then we call them hyperactive. So that extra activity, just like if you're hyper and you have extra energy. So who might have hyperactive bowel sounds? Well, someone who drank a lot of coffee, because we know coffee and caffeine increases bowel activity. Also, laxative use can additionally cause hyperactive bowel sounds. Sometimes early in bowel obstruction, they can have hyperactive bowel sounds at first, but later it's going to be hypo or absent, which again, to say absent.
Oh no, 20 minutes you're gonna be sitting
20
there.
minutes of your life, you're gonna be trying to listen.
Oh my gosh.
So then that hypoactive bowel sounds is if it's less than that 5 to 30 range. So you can't say it's absent, but they're either very light, so difficult to hear, but there's still a little something, which we can hear this hypoactive bowel sounds in patients who have hypothyroidism, maybe patients who are constipated, oftentimes patients after surgery when they come back and they're NPO after surgery, or NPO and they haven't had anything to eat or drink. So this is actually a pretty important assessment post-surgical, because when they come back, we don't want to start giving them a ton of food until their bowels are active and ready for it. Otherwise, we can cause an ileus or an obstruction. So oftentimes after surgery, and I worked a lot in post-surgical settings, we'd constantly be listening to bowel sounds and asking the patient, are you passing gas? And it'd be asking constantly, are you passing gas? Are you passing gas? Why do we care so much about our patients tooting? Because it indicates their bowels have woken up after surgery. And reasons why also they're at risk for that post-operative ileus would be narcotic pain medication, being more immobile because of surgery. Other people who are at risk for hypoactive would be aging, because we know as we slow down, everything stiffens up with that aging process, including our bowel motility can slow down. Pregnant women can also have slower bowel motility, partially because that baby's kind of a parasite. And as that baby sort of takes some of the nutrients from the food that we eat, that bowel movement slows down through time. Really, it's also because of those hormones, and hormones slow down all the smooth muscles in the body, and so including that GI tract.
So as you guys know, it's always about that baby taking up a lot of room, the hormones increasing, and all that blood flow increasing in the body. Now, another thing that can actually slow down bowel sounds or early bowel movements is being immobile. Our bedridden clients who are typically in a SNF or some type of skilled nursing facility, or for any reason, they can't get out of bed and move, which increases peristalsis. Now, the next key term to know is Borborygmi. This is a loud, gurgling type of sound, and we all hear it when we're hungry. Just not you when you're hungry. And, and your stomach just makes all these noises, right? So what is Borborygmi, and can you explain that more?
It's really just your stomach growling. So it's technically a type of hyperactive. But the thing is, usually, like you said, you don't even need a stethoscope to hear it. You can just be next to a person and hear their stomach growl.
Oh, yes.
And then the last term to know is an ileus, which I mentioned a little bit earlier. That's when someone has either minimal or no bowel activity. And so they'll have either absent or hypoactive bowel sounds. And so if someone came with an ileus, they would not have any bowel sounds, but they also might be distended. They're not going to be passing gas. And oftentimes that's a huge concern, and oftentimes they earn themselves an NG tube.
Oh, NG tube. Okay, nasogastric tube. Is that for gastric decompression or
yes,
getting...
absolutely. So next in auscultation, after we've listened in all four quadrants, starting the right lower quadrant, then going clockwise in that zigzag pattern, 3 to 4 spots in each quadrant, then you will flip over to the bell, and you're going to listen at that abdominal aorta. So between the xiphoid process and the umbilicus, a little bit to the left of that midline, and you're trying to listen for that bruit. So you're listening with the bell, and you're hoping that you don't hear that swoosh, swoosh. That would indicate turbulent blood flow, because then that would mean
we have a AAA. Now for a practice question. The nurse is auscultating the client's abdomen and is unable to discern any bowel sounds. How should the nurse proceed with the assessment? The correct answer is listen for 5 minutes before documenting an absence of bowel sounds in that particular quadrant. Now next is percussion, or basically tapping, and we want to use indirect percussion, so use 2 hands here. So let's see how this is completed.
So again, we're going to start in that right lower quadrant, going side to side in a zigzag pattern, roughly 3 to 4 spots in each quadrant. And so here, the abdomen gets its own percussion term that we really don't use for any of the other spots in the body. We call it tympany. And so tympany, it sounds like when you puff out your cheek and tap on it. And so that's what that tympany sounds just like your puffed out cheek. Because if you think about it, so before the terms we've used for percussion, resonance, which meant mostly air, dullness, which meant like fluid, and then we have hyperresonance. But if you think about even the inside of your mouth, you have some air, some fluid, some solid stuff. Also in your abdomen, you have some air, some fluid, some solid stuff. So it gets that own word meaning tympany. So how I like to remember it is I think tympany kind of sounds like the word symphony, and it sounds drum-like just like in a symphony you might have a drum there. So it helps me remember that tympany. So next step in our percussion, we can percuss for CVA tenderness, which like we said, it's different than the stroke type of CVA.
Right.
So this stands for costal meaning ribs, costovertebral angle. So you look at that costal margin, that margin of the ribs right here, and the vertebrae. And so where those two meet, you have this little piece of pie almost there, a piece of pizza. And that is overlying where the kidneys are. So if our patients came in with back pain or flank pain, and we were concerned for some type of kidney infection, we would percuss for CVA tenderness, or as I like to call it, the kidney punch.
The kidney punch?
So essentially, you're going to place your hand right in that costovertebral angle.
Oh, no.
And if they're having lots of pain, you can be nice and do indirect percussion.
Oh, wow.
Like this, or you can hit directly and see if there's any pain.
You actually literally punch the client.
The kidney punch.
Okay, and then we're looking for obviously pain.
If pain is elicited, then that can be indicative of kidney pain, versus if they had a musculoskeletal pain, it would hurt not just with the punch, but usually more with movement. So getting on the bed, or changing position could cause more pain. But specifically here, they might have pain with walking just because every time you drop your heels, you sort of rattle the kidney in its cage. But then when they sit here, if we were to whack and hit it, that would cause that pain. And so we'd want to investigate further for kidney inflammation or kidney infection.
Now, it's not just inflammation or infection. We can also assess for kidney stones, right?
Absolutely.
And if they have any type of kidney injury, or let's just say the client is guarding him, do an indirect punch, or just very lightly here, because we want to hurt the client less here.
So the last step of our 4 steps, if you think about our mnemonic, I always percuss patients. I inspect, auscultate, percuss, and then finally is palpation. But this time for palpation, we're going to do 2 types of palpation. First, we're going to do light. Second, we're going to do deep. So the light palpation, we're going to go through, again, starting right lower quadrant, going clockwise in a zigzag pattern. We're just going to use one hand, and we're only going about 1 to 2 centimeters deep. And right now, we're just trying to feel for generalized skin tone, musculature, watching for any tender areas or any guarding. Lots of times patients may say they don't have any stomach pain, but then when you kind of press, you'll see them wince. And so you want to investigate that further. So the first time through again is for any generalized skin tone and musculature. If you're feeling just any topical bulges or any topical growths or anything.
Or like any masses, or which can indicate tumors, or really just any mass at all.
Absolutely. So then the second one we're going to do with 2 hands. We're going to do deep palpation.
Oh, man.
So when we go deep, you're going to try to have the patient relax as much as possible. So now we're going to go about 3 inches or so.
3 inches?
And you want to imagine, because at first it seems like you're really poking into the patient.
Yeah.
But instead think about you're trying to find a hidden marble maybe.
Okay.
So you're trying to find any hidden masses, any tumors, or organomegaly, which is a fancy name for organ enlargement.
So just a mega organ?
Yes.
Okay.
And finally with this, you're going to start in the right lower quadrant and go clockwise like we said, unless the patient comes in already complaining of pain. If they have pain, you want to save that tender area for last, so skip it.
Okay.
So for example, if they have pain in the right lower quadrant, you'll start in the right upper, then go left upper, then left lower, and then there last. Because once you touch that area, the patient's not going to let you touch them anymore.
They're not going to like you at all.
But also they're going to be guarding and tensing up, and it's going to be harder to feel anything at all. So always save a tender area for very last. Now moving on to liver palpation. So there's 2 techniques, and here you're not really going to wrap your hand around the whole liver. You're really just going to feel pop, and it's going to feel like you're bopping the tip of your nose. However, if you had someone that was an alcoholic, someone who had an enlarged liver, then you might be able to feel a little easier. Also, we should not be able to feel the gallbladder. If the gallbladder were inflamed though, because typically it's hidden under the liver, it's its little buddy like we said. If it were inflamed, then it'd be poking out, and this would cause them pain. So what we're wanting to see is that there's no pain with liver palpation, and that we just feel a little pop on the tip of your fingers. So now we'll start with the bimanual technique. So Mike's going to stand at the patient's right side. Using his left hand, he's going to lift up the patient's rib cage. And then he's going to slide his right hand just underneath that costal margin. So we're going to have the patient breathe in to move the diaphragm out of the way, and sliding underneath that costal margin, you'll feel just the tip of the liver. And with the normal liver, you're not going to feel very much or feel very far. But we would just want to document that there wasn't any pain and that there was not any enlargement.
So once again, you're putting the hand underneath the ribs and asking the client to breathe in deep and really pushing down firmly.
You're sliding right under.
Bop.
Yep.
Okay.
Next, you're going to do the hooking technique. So this one you're going to be standing at the patient's shoulders, looking towards their hips. And you're just going to hook your fingers underneath that rib margin. So hooking underneath, and have the patient breathe in, and again, you'll feel that little bop, and there shouldn't feel any pain.
Oh yeah. All right. Now, does the client hold their breath for a certain amount of time, or?
They just kind of breathe in. Once you find your assessment, they can exhale and you're done.
Okay, just looking for that little bop. Now for a practice question. For which assessment would the nurse use deep palpation? The size of the liver is the correct answer. Not temperature, not texture of a mole, and not for bowel tympani.